Depression is different than mourning. Number one, depression is treatable. People don't realize it. It isn't mourning. It isn't appropriate for any stage of life because it is deep, it is dark, it is unrelenting. It isn't appropriate if you have cancer. It isn't appropriate if you are on the doorstep of dying or you have made great losses in your life. Mourning is appropriate, but not depression.
Hello, and thank you for joining our podcast, Hope to Recharge, a show that is designed to bring hope, inspiration, motivation, and some practical tips to those that are battling depression and anxiety, and to those that are supporting loved ones that are going through the journey in this difficult time of depression and anxiety. I'm here to tell you, you are not alone, and we will live beyond depression and anxiety. We will share our stories, one story at a time, in a world of mental health. Together is better. I'm your host, Matana. Thank you for tuning in. Hello, and welcome to Hope to Recharge. Thank you for joining me here today. Today I have a very, very special guest, someone that's near and dear to me, because I feel that by me meeting him, I was on the road to recovery. Dr. Samuel Pauker. I came across his name after I went to a different psychiatrist when I was really, really hitting rock bottom. I was sent by my local doctor to a local psychiatrist. Did not work out. And I was desperate to find someone good. Desperate, because I was desperate to heal. I was desperate to understand what I was going through. It was the beginning of my journey with mental health. And a lot of you know my story, that I went into a panic attack that led to another one, and then I hit rock bottom depression. And I just said, I need help. And my aunt is a therapist in Manhattan, and she deals a lot of time with psychiatrists in the city. And I said, give me the top psychiatrist. So she's like, you want the top? Dr. Pauker. So I'm like, how fast can I get into Dr. Pauker? And she said, give him a call. I think it took, I left a message. My husband left an SOS message that I didn't even think that I'll survive the day. And Dr. Pauker made time for us, and a lot of time, because the first intake took a few hours, and I can't express that feeling of relief, even though before I even got better, before anything, just meeting Dr. Pauker gave me a sense of he cares, he's there to help. Each story is different, and I left there thinking I'm not alone. So I'm so honored to have you here. Thank you for joining us. Thank you for clearing schedule, because I know how busy you are.
First of all, it's a great pleasure to be here with you and to sort of get feedback after all these years regarding how amazingly well you've done, and to see that you've embraced this particular task and goal of trying to bring a message to so many people about such a challenging subject. So this is really quite a pleasure to sort of have the circle kind of closed. So it's a great pleasure to be here.
Thank you. And thank you.
And you look great on the other end of that microphone.
A little bit better than last time you saw me. So
absolutely.
Thank God. I know that you're very, very busy, and I can speak to you for hours. Just leading up to this conversation, we spoke a bunch of times, and every bit of nugget of what you give me is so helpful, and I cherish it. And before we deep dive into the psychology and psychiatry and medicine and what is depression, what is anxiety, that people should understand a little bit more, can you give the audience a background of who you are and how you got into this field of psychiatry?
Well, my name's Sandy Pauker, and I'm on the clinical faculty at Cornell University Medical College, and an assistant attending at New York Presbyterian Hospital on the Upper East Side of New York City. I'm also on the faculty of the Columbia University Center for Psychoanalytic Training and Research. I've had a private practice in New York City since 1984. When I finished my residency. And so I have been treating people since probably the last year of medical school at the University of Pennsylvania in 1979. So I think this is my 40th year anniversary.
Wow.
Yeah.
Wow.
So, and I'm just in the process of writing a book about everything I've learned from patients over the last 4 decades. My training in my residency was as a general practitioner psychiatrist, which an adult psychiatrist treating people over the age of 18 till the age of actually to 102. And that's someone who is trained to diagnose and to treat people with a combination of psychotherapy and psychopharmacology.
Mm-hmm.
And having taken advanced training in psychoanalysis, I'm also trained in the ability to do psychoanalytically oriented treatments with people. I've also had an interest in family therapy, so I've done a lot of family and couples therapy. And my wife and I wrote a book in 1987 based on a nationwide study of newlyweds called The First Year of Marriage.
I didn't know that.
Yeah. What to expect, what to accept, and what you can change. She's a great interview also.
Okay.
And so she's a writer, and I'm a psychiatrist. Somebody thought that would be very cute to bring us together, and that turned out to be a great book. That's a whole nother topic we can talk about.
What is the name of the book?
The First Year of Marriage, What to Accept, What to Expect, What to Accept, and What You Can Change for a long and lasting relationship.
Oh, okay. And, I love that topic.
Yeah.
Phenomenal.
It was actually one of the first at the time to discuss the developmental process of becoming a couple and what the kind of stages are that people go through. At the time, my mentor was Dan Stern, who was the person at Cornell who was working on the developmental stages of babies and mommies becoming babies and mommies and the dances they do. Mm-hmm. And he suggested to me, he said, Sandy, why don't you do the developmental process of man and woman becoming husband and wife? And I said, well, Dan, that sounds kind of interesting. He said, you can start with Adam and Eve. I said, that's very cute. He said, you can use God as your co-author.
I love that.
I said, my wife's probably a better writer. He said, careful. You've got stiff competition. Anyhow, so I've done a lot of couples work, but also individual work. In the beginning, there wasn't that much psychopharmacology that we had at our disposal. Mm-hmm. So there were a couple of medications that worked maybe 80% of the time for 80% of the symptoms. But when patients came in who were extremely, extremely sick, and as psychiatrists, we got people who were very, very sick. Hospitalizations in those days were 3 months. This was trying to keep somebody out of a hospital who was very sick. You couldn't tell somebody that, oh, these medications are only going to work 80% of the time, and there are a lot of side effects, and there's only going to leave you 80% treated. That would be full disclosure.
Oh.
But you couldn't tell that to somebody who was in the depths of doubt and couldn't believe in anything to begin with.
Right.
So you had to basically tell them, yes, we have a potion here that's going to get you well. Mm. So in the beginning, it felt almost like being a bit of a charlatan. To have to convince somebody.
Right.
And this is just parenthetically, it's when I also became aware, I hope I'm doing okay here.
Yes, you're great.
But it's when I also became aware of the fact that in depression, that there was a linkage, a relationship between depression and belief, or the capacity for belief.
I remember when you taught me this. Yeah, I remember this.
Because when people became depressed, I became struck that they lost the capacity to believe in themselves, in life, and in the ability for treatment. They all developed that syndrome from they have in The Wizard of Oz, where each of those characters says to Dorothy, I don't think there's going to be anything in that bag of tricks that the wizard will have for us.
Right.
And that was the beginning of a whole nother little sidebar here of the relationship between belief and spirituality and depression and mood. But at any rate, you had to basically put folks on your shoulders and let them borrow whatever belief you could convince them of.
Right.
And at the time, it wasn't full disclosure. And it wasn't like today where we have such a wonderful armamentarium of things that we can do. We're really nowadays we're like shamans. We can wave our hands and make people almost universally better. And that's the secret people don't know. in the beginning, we had to convince them we were okay with very little.
Right.
Now we have to convince them that we can do almost everything. But at the time, it was ironic because as a kid, my father, who was in menswear business and owned a menswear knitting mill and sold menswear, I would go into work with him as a kid, maybe as a 10 or an 11-year-old, and I'd sit in the back with the salesman. And the salesman would be on the phone with the buyers. And I remember one guy in particular, he was the screamer. He'd be screaming on the other end of the line with somebody. He'd say, Joe, it isn't pink, it's purple. And besides that, pink's going to be the hot color this season anyhow. And they'd go on and on like this. He'd say, it's not the color that it looks like right in front of your eyes now. And besides, that's going to be the hot color anyhow. And there'd be 6 guys in a room. They'd all be screaming the same thing. And then they'd get on the phone with the guys at the mill and they'd say, how dare you send the buyers all pink? So I'd be sitting there listening to this and I realized I'm never, ever going to be a salesman. I could not possibly lie bald-faced to people like that.
Yeah.
And I asked my father once, I said, how could they do that? He said, well, you want to know something, Benny? None of us can have such, aesthetic grandiosity as to know in 6 months what people are going to want to wear. And the fact of the matter is, in 6 months, they may well want to wear pink. Right. We can never possibly tell where people's heads are going to be. And I thought that's very wise. As I was sitting there with patients and having to sell them on a medication that I only thought was 80% good, right, I had that guy's voice in my mind. And as I was telling patients, don't worry, this stuff isn't pink, it's purple. And besides that, it's going to do you as well as purple. It doesn't really matter. Right. So all that stuff that you thought was the worst thing you'd ever heard in your life actually turned out to be what allowed you to sort of stretch things a little bit. But as time went by, we've lived through a couple of decades of research in the brain, and it's really been quite miraculous. And although there's a lot of skepticism that people have about fiddling with their brains with drugs, and I share that as an innate part of all of us that feels, don't give me drugs. We all grew up with that, Right. But the fact is, God has been unusually good to us, and we have at our disposal maybe 5 different classes of medications, and we can target mood, and we can target cognition, and then we can target more subtle forms of mood and anxiety and energy. Right. And so the kind of work that I have found myself doing over time is what I call psychotherapeutic psychopharmacology, or psychotherapy guided psychopharmacological therapeutics. What does that mean? It means that I don't do a 15-minute kind of pharmacology. There are those places. In fact, most of the psychiatry in the country happens in clinics where you would come in. I'm not disparaging it, right, because it's where most people get treated, and it is the cost-effective form of treatment, where you'll go in and you'll fill out a long checklist of symptoms. And so by the time you walk into the doctor's office, he's already seen a whole laundry list of symptoms, and he will then basically almost have the formula that he's going to prescribe for you before you open your mouth. But in my world, I still do a very long interview with somebody, and I use the finding out about your symptoms to really get to understand you. Right. Because each of these symptoms may be buried in a whole story. And as you get to know... Can I add something to that? Yeah, absolutely. I want to add that when I met you for the first time, the fact that you didn't do it in 15, 20 minutes, half an hour, and you gave me, I think it was 2.5 to 3 hours of intake. First of all, it gave me hope that you really cared because you're spending the time with me. Second of all, it also gave me hope he's going to understand because he heard me out and he asked almost every single question needed in order to diagnose me. So when I left with a sense of real hope of, oh, he's going to get this right. It's not just, here's a prescription
and you were very clear, and you went through step by step explaining the different reactions to what I'm seeing and what I'm feeling and the why behind it, which gave me so much strength. Every single time I went through an episode of a panic attack or extreme depression, I was hearing your voices explaining it to me in my mind, and it helped me every single day. Besides the fact that I knew that you told me, we're going to work with a cocktail of different things. We're going to see what works, what doesn't work. Nothing is right away. And the fact that you gave me so much time, I think, was much of my hope to recover.
You are really pretty amazing that you remember all of that.
I do.
Because you throw a lot of things. I really use the spitball approach, and you throw a lot of things at the wall. But hearing all that out in the detail that you just mentioned gives people the sense that you really are hearing and really getting on the inside of what it is, their experience is. And when you tie it all together at the end, and you say, hey, listen, the sleep problem and the focusing problem and the appetite problem and the sex problem and all these things, which people really don't see as all tied together.
Right.
And then you tie it all together and you say, lo and behold, what you thought was so unusual. And I say, I hate to tell you, I know that you feel that you are an unusual person, and everything about you is unusual. But this condition you have is actually right out of the textbook.
Right.
So this actually, what you think is the most extraordinary, actually is the least extraordinary.
Right.
And it's right down the center of the fairway. And so that actually is really eye-opening for folks. And you can do that when you really take the time to really listen to it very carefully. And when you then say, this is how I think I would go about treating it, it gives it more authority. And you're not just throwing some medicine. You then have the ability to say, and this is why I would use this medication, because it would be especially good for that symptom.
Exactly.
And it would avoid that side effect.
Right.
So, so this kind of really listening carefully pays off. And as time goes by, and the nature of the treatment is that certain symptoms will respond right away. And certain symptoms will take a little bit longer. And so because the treatment of depression takes a full 3 months for these medications to work fully, then you've already set all that up right from the beginning, that your sleep may respond right away, but the existential dread that you have in the morning may not respond until month 3 completely. So we're not going to think that what we're doing is a failure because you're eating better and you're functioning better at work and you're sleeping better, but you still wake up in the morning and don't know why you should go on with your life.
Right.
So, so there's a lot of aspects to the experience that you really want to have a patient come away with, as you said, so that down the line it still plays in their head. So I have a lot of patients who, at some point, they will come off the medications.
Right.
And they may come to rely on other strategies for maintaining their mood.
Right.
Having brought down the intensity of symptoms pharmacologically, people are able to utilize other, you might say, what's called technologies of the self, like yoga and meditation, which may get swept away when symptoms are in the 0 is nirvana and 10 is hell. Then when it's up in the 7, 8, 9, 10 range, meditation and yoga kind of get swamped.
Impossible.
When you use the pharmacology early on, bring down the symptoms to the 4, 5, 6 range, those others really prove to be invaluable. And now you can get things down to the 2, 3, 4 range. So when you pull back the medication, you now have the benefits that you have accrued to yourself with cognitive behavioral therapies and with yoga and with meditation. And in fact, it's always my one of the things I also don't tell patients is that midway through the treatment, I'm going to really, really, really tell them, you really have to go and get into a yoga class now. It's the only thing that'll save you. Knowing that after we pull back the medication, this will be life-changing for
Exactly. I want to tell you that you told me that in the beginning.
Oh, yeah?
That's what that was so refreshing. I remember when I came to you, I wanted the medication medication, but I was afraid of it. Like you said, people told you no medication, no medication. We grow up and saying medication is bad, medication bad. It's addictive. And I knew I needed something. At that point, I knew I needed something, but I kept on saying, so will I need it forever? Will I need it forever? And your words I say till today, sometimes you need to get on it in order to get off of it. And you explained that to me. And you explained that to me that exactly what you said before, that when you are at a 10 or a 7 and you're fighting, you're battling, there's no way you can relax into yoga. And you told me you're going to go to yoga, you're going to go to meditation, you're going to start therapy, and it's going to be a cocktail of healing. It's not one thing. And I think what is so unique about you as a doctor, a psychiatrist, that you introduce that in the beginning to the patient and you tell them that it's not all or nothing. You have to find the balance. You have to find what works for you. And you have to also do the emotional work. It's not enough to just pop pills, because pop pills will numb the symptom but won't fix the problem.
It saddens me to think if I'm the only guy who's telling patients this. So I'm hoping that there's a lot of us out there. However, I do know that as medicine has changed, doctors are under more and more time limitations. Mm-hmm. And I just personally have committed myself to really finding out, what is the formula that actually will work to solve this particular problem. So when people come in, frequently the first things that they'll tell you, because they're thinking very depressed thoughts about treatment, they'll say, I don't want to be on these medications forever, and I don't want to be addicted to them. And
or the side effects of them.
The side effects. So you give legitimate answers, but at some point you have to point out those are all depressed thoughts. Yeah. When somebody says to me, I don't want to be on these forever, the first thing I say is I can't help myself anymore. I say you only have to be on these for 50 years. Nobody stays on them a day past 50 years. It says right on the label. So they all look at me like. So for the first time, you can get somebody who's depressed, like either smiling or looking at it.
I like
you're
that.
Crazy. Yeah, or like you're crazy. So it's very helpful for somebody who's been going around thinking they're crazy to look at you like, oh, he's crazy. But these are all, and then you can point out to somebody that all the thoughts you're having about the treatment are the symptoms that we want to treat.
Right.
Because you're having all the most negative, you're going to be dependent on it. Right. You're going to be, it's going to make you a zombie, or so.
The fear factor of anxiety.
All those feelings. But as you go through this, behavioral changes like yoga or meditation or even prayer aren't so easy for a lot of people. A lot of people would like to have a pill kind of that solves it all.
Yeah.
To some extent, the fact that it takes an extended period of time for these treatments to really take hold give us a chance to really work together to try to make some changes in a life that can really be life-changing. Again, in the old days, people would be in the hospital for 3 months.
Right.
Automatically.
For depression?
Yeah,
Really?
Yeah, for depression for 3 months, because in the middle of the treatment, people would still be, depression is like a sine wave. It waxes and wanes. You may feel a little bit better today, a little bit worse tomorrow. So you could make a plan today to go have a business meeting, and tomorrow you'd fall flat on your face and you can't open your mouth.
Right.
So when you're in the hospital, we would carefully monitor what kind of meetings you were planning. Mm. And if you were going to go be meeting with your potential bashert, right?
Right.
On a date, we would say, not a good idea. You might be blowing your future. Why don't you wait until you're really better? Because you don't know on a call Monday whether you're really going to be able to keep it on Thursday. Oh. So don't make any plans that you can't cancel.
Okay.
And as a result, we really discourage folks from making any important life decisions until they're at the end of the 3 or 3.5 months. So in the hospital, we could really do that carefully because people had to sign out.
Right.
So, wow. But nowadays, it's a 9-day almost max to be in the hospital. So you have to really set up the rehab program with the patient. That means signing a medical leave of absence from work and making sure that folks realize that they may feel better today, but they may not feel good tomorrow. And don't make plans that you can't bow out of. And don't blame yourself, and treat what you have like it's a bad pneumonia that may take you a few weeks to get better, and you will be better. It's just that this thing takes some time.
Can I ask you a question on the hospital stay? The people that go nowadays for the 9-day treatment, is it because they had a manic episode, because they were suicidal? What makes somebody say, I need the hospital nowadays?
It could be that this was a first time kind of break of some sort, and so they may be acutely suicidal. It could be that they have been down and depressed for so long at home that the families, good families, have gotten exhausted. And they need the break. And they need the patient to be hospitalized so it can be clarified for them that, yes, you have done everything you can, but the patient has a real condition. It's not just a condition of you giving them more chicken soup. Because most people don't know what the condition is. So they have inadequate expectations about it. So those 9 days, which really aren't enough time to do anything but get somebody diagnosed and get something started and get them back out with their outpatient, get them patched up, is sometimes just enough time for the families to catch their breath.
Wow, I never knew that.
Yeah, so in fact, an exhausted family is of well-intentioned people who can no longer bear someone, is itself one of the key diagnostic features of a major depression, as opposed to a mourning, mourning.
Oh, okay.
If someone's mourning, people go over to you and they say, geez, I feel terrible for your loss. And we pay a shiva call, people go over, and then the person may talk about the person they've lost. In a shiva call, somebody is talking about something different every 5 minutes.
For people that don't know what a shiva call is, because we have a lot of non-Jews on this, shiva is 7 days after we lose a close one, a father, a mother, a sister, a brother, a child. We sit for 7 days in mourning, and we have visitors come to give condolences.
So anybody who's visited someone who's lost a close relative or a close loved one knows that when they go to visit such a person, they may be deeply in grieving 1 minute, and the next minute you may be laughing and talking about some funny incident. So the mood is going up and down like a roller coaster, but you can relate to it all. And the person relates to you. And the usual rule of thumb is follow the person's mood. When you're with somebody who's in a major depression, on the other hand, there is no going up and down. The person is in an unrelenting, deep, dark state. There is no laughing about it. And as a result, you become, as a caring person, you get fatigued and exhausted. Worn out.
And nothing to give.
Nothing, and there's nothing to give because there is no help that is being received. And so it's often when the families are totally exhausted that they'll finally bring somebody in for the treatment because their own grandiosity has been exhausted, that they can't help. So I tell residents that the exhaustion of the family is a key symptom. So if you are treating somebody, a patient who is telling you that they have somebody at home, Uncle so-and-so or Grandpa is been exhausting them and they can't take it anymore, get Grandpa into treatment. He has a depression, needs treatment. You will help your patient, you will help Grandpa, and then we will, and if you, the resident, don't understand this, we will discuss it later. In the meantime, get the treatment going. But so depression is different than mourning. So the take-home messages really are, number one, depression is treatable. People don't realize it. It isn't mourning. It isn't appropriate for any stage of life because it is deep, it is dark, it is unrelenting. It isn't appropriate if you have cancer. It isn't appropriate if you are on the doorstep of dying or you have made great losses in your life. Mourning is appropriate,
Oh.
but not depression.
So can I wait? I have a very important question right here, right here, and I don't want to forget it. So you're saying there's a difference between depression and a deep sadness of a loss. Can someone
major difference?
So can someone go into deep clinical depression from a loss, from breast cancer, from losing a child, God forbid? Can someone go into that from mourning into deep depression?
Because there is a milder form of depression called dysthymia, dysthymiA. Maybe we can talk about this distinction later, another time. Dysthymia is a milder form of depression. It's not the kind that you are in bed with the covers over your head and the blinds closed and you can't get out of bed. That earns you a trip to the hospital, right? But dysthymia is a milder form. Your high-functioning people are still working, but they are carrying a weight around on their shoulders. They are living on the cloudy side of the street. And although if things are going right, they are able to live on the crest of the wave, the tiniest little, what's the expression, molehills turn into mountains. So at work, they are irritable. They have quick flaring tempers. They are more prone to things like alcohol or other things to try to raise, other distractions to try to raise their spirits, like having a quick affair. Dysthymia, we used to think of as like a depressed personality, except that now we know that there are medications. When Prozac came out, that was the first of the medications that sort of treated these milder depressions. Now, because 1 out of 3 of the people that you know are walking around with a mild depression, when one of these tragedies affects them, it is possible that that will push them into a deeper form of the depression. And they will have a protracted mourning or have more trouble pulling out of their mourning. And you'll notice that on the condolence calls and all, somebody who isn't responding to the visits and they are just more intensely grieving. There's nothing wrong with grief. And we are internalizing someone in grief. We're having an inner discussion with somebody when we're grieving. But if you think about it, all the people you've known who you've seen grieving, there's a broad spectrum. And some of those people will need to have been so shocked or traumatized or having some post-traumatic stress from the loss, or maybe even have been pushed into a depression from the loss. So the problem with being in a depression when you have a loss is you can't mourn when you're depressed. You can't mourn when you're depressed.
So you're never ending it.
Yeah. So in depression, you're just playing the same thing over and over in your head like a broken record. And in mourning, you're playing it, but you're learning from it. You're internalizing it. You're going through those steps of Kubler-Ross where you're in protest and in anger, and then gradually making your peace and some reconciliation, and then acceptance, and really internalization, and then maybe you make a dedication to the person who you've lost, but you're actually growing from the loss. In depression, you're just stuck and just in a deep. And we've all seen people who have had a terrible loss. Somebody I saw recently who lost a 2-year-old who is still, a year later, threw a birthday party for this deceased 2-year-old and made everybody come and put on birthday hats and and they had to sing happy birthday. So this is a really
is that healthy?
That's a highly pathological form of mourning. I think everybody can see that this woman's still deeply, deeply depressed. And
so it's not a good thing. It's not like, she's stuck. She's stuck in that.
So the patient was asking me, my patient was asking me, what can we do? Because this was a sister-in-law. I said, you got to get this woman into treatment. And they said, how? I said, well, the first thing is you might want to point out to her she seems deeply unhappy. So she said, well, of course she's unhappy. She had this loss. I said, well, yeah, but that kind of depth of unhappiness doesn't seem to help anybody, right? I mean, And so you can still, people don't realize you can still mourn, even though you're not in a deep, deep state of
depression.
unhappiness. But this is different because this is a matter of, I need to suffer. How can I go on living while my child has died? So that's a different kind of, so depression will accentuate your, not just your sense of grief, but your sense of needing to suffer. So,
and is this something medication helps?
The medication will definitely help you to get over it. But we started off by talking about how one loses belief in depression.
Right.
So you lose belief, you might say, in the good and the forgiving God.
Yeah.
But you maintain a kind of belief in the demanding, you might say, and the angry and the accusatory and the killer God, you might say. So that's a different kind of, so, we should, all of us, be on the lookout. One goes and tries to publicize such things on the air with you and the work you're doing, not because they're downers, but because there aren't enough mental health workers. There aren't enough doctors. The number of people we now know, now that this is not as stigmatized as it used to be, is enormous. And so each one of us really, everybody put up your right hand. We are all deputized.
Right.
So anybody who's had this condition becomes a kind of beacon of light just by virtue of the fact that they were down and now they've come out of it, and light is emanating from them once again.
Right.
So because it's a mixed crowd we have, because the spirit is shining once again, I have a belief that other people are going to see it, and consciously or unconsciously they will wonder, well, what happened to you? So everyone who has been treated is a gift from God to other people. Right. That they will somehow wonder, and at some point they'll say, what happened to you? You used to be so down.
Right.
And I tell people as they're getting treated and they get out towards that 3.5 month point, I point out to them, you will be a beacon of light. People will come over to you and say, what's happened?
I like
this
that.
This is part of your our graduation discussion.
I like that.
And if you choose to so embrace it, then you'll have an opportunity to turn your grieving couple of months into some benefit for others.
And giving back.
By giving back, you'll see a coworker who's walking around, and you'll have an opportunity because of where you were. You'll be able to say, hey, I was where you were at, and you just look down in the dumps and you don't need to be. So I think that really folks who've been through this are really the front line. Right. And because there ain't enough of us.
Share your story, share your experience.
Share your story, and this is how the front line will be advanced, really. It won't be from the generals. It'll be from the foot soldiers.
I have a bunch of questions if I have more time.
Sure.
Do you have a few more minutes?
A couple minutes, sure.
Okay, I have a few fundamental questions if you can answer. You told me 9 years ago that depression and anxiety come together. They're sisters, brothers. They're always linked to each other. Can you explain in the brain what that means and why is depression and anxiety together?
When people come in, sometimes the mood will be, depression is a misnomer for a condition for which the mood may be depressed or anxious. There is a cognitive component. Usually the thoughts are very ruminative and negative, characterized by difficulty having positive thoughts and an emphasis on the negative. And then there are somatic signs and symptoms like difficulty sleeping and appetite and enthusiasm. So you have those three categories. But in terms of anxiety, so if you're thinking negative thoughts, you're going to feel anxious. You may also feel depressed. If you take your anxious thoughts a little bit further, in some respects, sometimes anxiety is a defense against depression. People will be anxious
to get over it.
Well, the adrenaline of anxiety will actually block the feelings of depression for some people.
Oh.
Yeah. So that I have some folks, when you begin to treat them for depression, they will get suddenly extremely anxious.
I remember I came into your office and I said, I feel my toes. I wake up in the morning and my toes are always tingling. And you said, oh, that's a good sign because it means that the medication is starting to work and the anxiety starts with the toes, but it means that depression is subsiding a little bit.
Kind of lifting.
Yeah.
So, and sometimes you'll treat the anxiety because in the beginning, sometimes anxiety will be so great that we'll use the anti-anxiety drugs, which will work rather quickly.
Mm-hmm.
And so somebody will now not be tremendously or overwhelmingly anxious, but they'll come in, they'll say, Doc, I am just so depressed. And then we interpret that the medication has unmasked the depression. And no, the medication has not made you depressed. It's unmasked it. And the correct thing to do is to treat right through it. So some people, because the antidepressants will actually work on anxiety as well, because they will quiet down, you might say, the adrenaline that's surging.
Mm-hmm.
And so people can misinterpret because their anxiety, because the adrenaline had been keeping them pumped up and masking their depression.
Mm-hmm.
When you kind of start to quiet down the body's anxious reactions, which have been practically killing them because they've been feel like their heart's been thumping,
right,
stomachs have been tight and everything. But then they begin to think, oh, this medication makes me want to kill myself.
Mm-hmm.
So you don't want anybody to kill themselves, but the medication is not making you depressed. Medication may be treating the anxiety,
mm-hmm.
but it is unmasking the depression.
Mm-hmm.
And so you have to treat right through it. Mm-hmm. Sometimes you may have to raise the dosage a little bit, go a little bit faster. But remember, the treatment takes 3 months. So in the beginning, the first couple of weeks, the anxious symptoms may respond faster because that's about quieting down the body's adrenal response, the fight and flight response.
Mm-hmm.
But it takes a little bit longer for the medications to get to the parts of the brain where the depressive reactions seem to get cued, right. Or rather where the ability to be happy is suppressed.
Right.
So that's why you will often see anxiety relieved relatively quickly, but depression suddenly unmasked. It actually makes the first couple of weeks of treatment a little bit risky, and you have to watch somebody carefully,
right? Because
suddenly the anxiety is relieved, but now suddenly somebody may suddenly feel suicidal.
Exactly.
And it is a misnomer. I know some people think that some of the antidepressants are suicidal inducing. In my experience, that's incorrect. They're not, but they have unmasked something, and you have to stay in touch with the patient. They have to know what's going on, and you have to treat right through it. Right. And you will treat right through it, and that will be relieved within a week, but you may have to give them more anti-anxiety medication like some Clonopin just to kind of quiet that down a little bit. Mm-hmm. Better to be a little bit stuporous and not suicidal, but to get through that week. Again, in the old days, we had people in the hospital, you'd keep somebody in a slightly stupor state for 2 weeks.
Wow.
So we would just take a vacation of the mind, just sleep your way through it.
Right, until the medicine kicks in and takes over.
Until it kicks in. Right. Nowadays, you have to be very careful that you explain to people. Right. And because everybody's doing this, I remember in the beginning, when I started my training, we became aware that in China, people get patched up in hospitals and they'd all go home, and everybody in the family became like the nurses. Right. And they call that Chinese medicine. You get immediately discharged, and the family were all nurses. And little did we suspect that we were going to all be practicing Chinese medicine here, that everybody was going to get patched up in hospitals and you were going to be sent home. The way we phrase it is to be taken care of by your doctor in the outpatient setting. But what it actually is to be taken care of by your family.
Right. And yourself.
Which
is the number one. How quickly do you check up on them once they come to you? Like, what do you recommend for people that are listening that's they're thinking about going to a psychiatrist? What would you recommend the cycle of visits to psychiatrists?
In the beginning, because, in the first visit, you're being diagnosed, having explained to you a lot of stuff that you may know nothing about. in the first visit, some psychiatrists would break up an initial visit into 2 visits because it may take, just to make the diagnosis would be visit number 1, and then to come back to go over the treatments and to get them started.
Mm-hmm.
And then because you're starting some new medications, which may include an antidepressant, maybe an anti-anxiety medication,
Mm-hmm.
they may want to see you the following week just to see how you're faring. Are you feeling more depressed? Or indeed, is the medication working and less depressed? Are you using the anti-anxiety medications correctly? Do we have to go a little faster, a little bit slower? It's every psychiatrist's guess about how quickly or slowly to go, depending on your circumstances. So in the beginning, it's not unusual to be in contact with somebody maybe once a week for a couple of weeks,
Mm-hmm.
just until the medication is up and running. And then you rather quickly can cut. But once somebody's familiar with how to use these medications, then you can, and they're not difficult to learn how to use.
Right.
The anti-anxiety medications, Klonopin, those types of drugs, very easy.
Right.
Once the antidepressant is built up over a week or 2 to its therapeutic dose, pretty standard. So it's not that tough, and within a short period of time, you can be back to, let's say, once a month to see somebody, and then once everything's kind of rolling, most people I see in maybe 3-month periodic follow-up for medication checks, and you can do a lot of that. Some of the medication check on the phone. You really should see somebody depending on the medications, every 3, 6, 9 months.
Mm-hmm.
Because there are things you see when you eyeball somebody that you might miss when it's just on the phone, even though there's telepsychiatry today. But that's another topic. But I'd say in the beginning, you should be in a little more contact. The problem is that for half the country, half the psychiatric medication in the country is prescribed by internists, non-psychiatrists.
Wow.
So they are going to give you 20 milligrams of Lexapro or something like that. And they'll say, they don't have the time to see you again for a couple of weeks or a couple of months. So they're going to give you just something that's the easiest to give you.
Wow.
Not anything that's going to require any fancy. They're not doing psychotherapy guided psychopharmacology.
Right.
So they're just doing, but they are the ones who are there.
Right.
Psychiatrists don't go into the hinterlands, So.
But that's a big problem.
You can translate that. So,
it is a problem.
Dr. Pauker put his hand up in the air
and says,
"What can we do?"
Right. What could we do? How often do you take let's say your patients are on it for a year or 2 and they're like, okay, I don't like the side effects, I'm feeling better. How often do you see your patients doing the work of going to therapy, yoga, meditation, and they can actually get off medication and be okay? What's the percentage?
Well, after it takes 3 months to write the bottom line, see what the formula is that works, and somebody is hopefully back to themselves. I take that back. They're better than themselves.
Right.
Since most people were schlepping along some anxiety and depression beforehand,
right,
they're better than they were.
Right.
So at that point, you want to let maybe 3, 6 months, maybe 9 months pass, and just see what they do with, now that you've revved up the engine, let's see what people do. And that's actually a very rewarding period, because you see people do all kinds of things that they weren't before. I know one person who started a whole audio blogging site for depression. And so creative stuff starts to happen. At some point, you would begin to ask the question, why don't we cut back? And you would do it slowly and step by step, almost the reverse.
With monitoring.
With monitoring, maybe if you were on, because you would do it the reverse of the way you went on it. Maybe you'd cut back 25% of a medication and you'd wait a few weeks to see how that affected you. So a few things can happen. One, when you make a small cutback, you feel the difference. In which case you say, no, let's go back on it. And then you stay on that for a few more months, and then you try it again. Sometimes you'll cut back to a low dose, and when you go from a low dose to 0, you'll say, no, I feel that. I feel the difference. So you'll stay on a low dose as a maintenance dose. Sometimes you'll go off of it and you'll be okay, but because most of these conditions are recurrent, but the medications are prophylactic. Sometimes you'll stay on a low dose as a prophylactic, and to that, it depends a little bit on you and your lifestyle.
Right.
So if I'm treating somebody who, most of the people I'm going to see in New York, because they're high functioning people, they can't afford to get knocked out for a couple of months.
Right.
If you were a moonshiner up in the Ozarks, and all you're doing is sitting around and waiting for those potato spuds to grow to put into that moonshine machine, maybe, if you were knocked out,
right,
for 3 months, who would care?
right.
But most of the people you see in New York City, 99% of capacity doesn't cut it. They want to work hard and love hard. At that point, when people ask me, what do you think I should do? Far be it from me to tell somebody to stop something completely that might expose them to a painful condition. I'm very phobic about my patients' depressions.
Dr. Pauker, did you ever suffer yourself from mental health?
I've had touches of that. So I have a little sense of, not as deep and as complicated as patients of mine have had, but I have a sense of what people may go through. And I've sat with people for so long and have, empathized with people for so long.
My question was leading to, do you get what we're going through, even though you understand the chemicals in the brain?
But I think so.
You think so?
I think I get,
the darkness.
I've been through things in my own life, I don't think it's quite like, if you're familiar with Rabbi Soloveitchik's book, Lonely Hearted Man. You familiar with that?
No.
So he wrote a really quite remarkable document in which he really describes what was probably his own either depression or kind of crisis of faith. And maybe they're the same, but he described it as two Adams, Adam 1 and Adam 2 from the Bible. For those who are listening, if you remember your Bible, there's the Adam who it bounces up sort of all perky and is naming the animals and is industrious and goes to work every day.
Right.
But there's another version of Adam in which God is sort of almost hiding, and God comes to him and says, "Where are you?" And Adam is almost hiding, and God has to go find him, and he's not in a very good state. And the rabbi identifies these two parts of himself. One is the person who's known in his community and is doing all kinds of things, but there's another part of himself that occasionally has a voice whispering in his ear that just says, "Where are you?" And what are you doing? And so all of us have those moments, right?
Right.
And so, and those can be very deep and very profound. I think that those are, we can talk more about that.
And that's what connects you to the patient? Do you think that's
I think that more than connects you to the patient. And it's what some patients, there are some people who get into that kind of a depth when they're in depression. And there are others, you might say, who almost avoid that kind of a depth.
Right. Yeah.
When they're in other words, there are those who have written about the deep, dark night of the soul. Right. Which is a form of depression. There are those who think that as a result of that, you wrestle with a form of spirituality that is, when you come out of it, makes you even spiritually more solid when you integrate that. But not everybody goes through that.
I had that. I had that. Yeah, I was very disconnected from God. I was raised very God-fearing, Orthodox, and there was a time that I just didn't see God. I didn't see God. I didn't believe God existed. It was hard for me to fathom that a God can do something so dark. And there was such a lack of spirituality and growth inside me that I almost hoped there was no God, because this can't be real. And then there was an awakening moment that I said, "God, if you are there, prove it to me by me getting healthy." It was my little vow. I remember where I was standing and I said, "God, I'll forever pay it forward if you heal me, because this darkness is so dark and it's so debilitating, and I can't take one more day of it. I just want to heal. It was a process of healing, but the process was up and down, up and down, up and down, up and down. But when I will never forget those words that I said, because I really meant it. I was seeking something. I think when we're so down, depressed, and there's no hope, we want something higher than us, because we're depleted. So we're hoping that there's something, there's a higher energy. So not everybody believes in God, but people believe in energy. Everybody believes in something else that lifts them. For me, it was God. For somebody else, it's the universe. It doesn't matter. It doesn't matter, but it's something greater than us. And and I find also that deep analytic minds go into depression more often because they can't figure things out. Do you see a relationship between that?
Absolutely. I think it's absolutely. And I think it's really something that you can actually remember the moment or the period that you were actually, I hope you wrote it down, but that you actually just spoke it out here. So that's good. Everybody should listen to that, because I think that's a really, it's almost numinous, when you go through a period like that, and because you never forget it. And I think it's soul searing.
Yes.
SEARING, and integrating those two really, I think, changes a person and makes you alert to your fellow man's. Some people go, and it's hard to figure, but some people are just geared towards that, or have that I think it's a capacity, because it's a very vulnerable state to be in. And some people, you'd think, how could you not possibly realize what you're going through? But they're like almost warded off and defended.
I want to touch upon this new book that you're writing. If you can explain, I think it's about body, mind, and soul together. What is the relation?
It is gonna have components. It's about so you have depression, you can cure it, and it's about the fact that depression is close to 100%. In distinction from when I began, and I had to be a charlatan. Nowadays, depression is, if you do it the way I've been describing it, by really understanding what you have, and with a vast variety of things that we can do about it. Depression, I haven't gotten into some of the newer things like ketamine and psychedelics, but depression should be just about 100% curable, with close to zero side effects. And so
with medication, you're saying curable?
For starters, with medication to get you out of it, but on the road to the medication, there should be, to get to the psychopharmacology, you have to go through a psychotherapeutic process of understanding yourself.
Right.
It may not be a psychoanalytic process, but it may not need to be, because you are so deep into it to start with.
Right. Right.
And but that in the course of it, to get from that, as you are walking your biological gradient, you find that there are things can only be walked with a psychological gradient, like with some CBT, and with a mind-body gradient, right? The medication will not do for you what controlling your own chi will do for you, your own meditation. And so you can have others shifting models of the mind and the body totally, although they can be translated into each other. But in the East, they talk about chi and energy, right? So, which we can translate into the vagus nerve and various things. So you can have somebody else work on you, like with massage, and move your energy around, but you can learn how to handle your energy yourself with things like yoga and things like meditation. So yoga in particular is amazing, because in yoga, you put yourself into a stressful situation, right? You create a kind of artificial stress. And then, lo and behold, you're breathing deeply. And so you're relaxing yourself, right? So you are conditioning yourself that when I am feeling stressed, I automatically go into relaxation state. This is amazing, right? That when I am stressed, I automatically go into a relax. I am Pavlovian like a Pavlovian dog, I'm retraining myself that when I feel stress, normally when you feel stress, you just get
Tighten
more
up.
stress.
Right.
But instead, when I feel stress, I go into a relaxation state. I deep breathe.
Right.
I
Right.
maybe go into a posture, and I
Right.
completely change my mental set when I'm stressed. So this is an amazing. So as anybody who's listening, you could not, if you were wondering for a sign from God, what should I do to help myself?
Right. Right.
Help myself deal with stress in my life.
Right.
This is it.
Right. Right.
So that is, and we've touched here a little bit on how issues of the soul come in, but this is so individual and particular
Right.
that it's probably not a general discussion.
Right.
Although it's something that has interested me tremendously, and I've been in study groups for 25 years about this subject, but that's for another time.
Is it going to be in your book?
It is going to be in my book. The book's going to be, a lot's going to be on the pharmacology, and then there's going to be a section on the very basic meditation techniques, which is going to be basically a do this now. Do this absolutely right now. And you're going to get points and prizes if you do. I'm going to get a coupon to go to an ice cream store if you do
From you?
now.
From you?
From the book. From the book. If you do it and you're honest, you're going to get a coupon.
Wow.
And then there's also going to be something on the psychospirituality of it, because if you do meditation, you may actually find yourself wandering into the real meditative state. Has a little, it's going to have a little bit of a discussion about what you described as those numinous moments. So we used to call, Abraham Maslow used to call these aha moments that you have in therapy. He called them aha moments. So I've come to understand that those aha moments, which happen, why should you pray? Because you can get more of those aha moments.
Right.
So
Okay.
you can do them in therapy too.
Right. Or in meditation. Right.
Or meditation. But the meditation and the prayer boys knew about this a long time before the rest of the psychology guys figured it out. Reading people like Jung, there's a lot of reason to believe that those numinous moments, those numinous spiritual moments, may be the very core of the therapeutic healing process. So
when is this book coming out?
Just finishing up now, and so hopefully, within months, I'm just having my editor read it over, and but I'll let you know.
Yeah, we want to have you on again to just discuss the book in depth. And do you have a name for the book?
Working on a couple of different names,
So we'll leave it for next time, the name and a little bit deep dive into the book. I want to ask you two more questions. What would be 2 tips you would give someone that is living with someone that is suffering but doesn't want to do the work? What would you give the loved one? The fundamental 2 tips that they could do to not come down with the ship, or to help them get help when they're in denial, or don't want to, or they're afraid to.
The number one thing is that you can, if somebody's in total disavowal, is that you can point out to them out the corner of your eye. Number one, not to get into a battle over this, because if you find yourself getting into a battle over you're depressed, no, I'm not, no. If you find yourself repeating the same thing 3 times in a row, with escalating volume in your voice, like you're talking to a cabbie who doesn't speak your language, then you might as well just back off, because of 3 things. 1, the other person's heard you. Otherwise, they wouldn't be putting up a defensive wall, right? Because that's what it means. 2, they've heard you and they understand you. Otherwise, there would not be a defensive wall being put up. Even more so, they agree with you, or part of themselves agrees with you. But the problem has just been externalized. Now they are fighting with an internal part of themselves projected onto you. So that if you give somebody a piece of advice like, why don't you get a consult, or at least, and they start to jawbone you, you can immediately back off and say things like, you have a good point, hon. You agree with them.
Mhm.
That makes it harder for somebody to disagree with you. So if you make a suggestion and you start to get a defensive reaction, if you have the wherewithal, because most people immediately get defensive themselves, but if you have the wherewithal, back off, say, oh, you have a good point, hon. I'm going to think about that. Leave them holding air, not your neck. You follow? And the other thing is, the one thing that you can say that might get somebody's attention is, you seem unhappy. You don't have to go into any of the other details, just, and you can do that, I call it out the corner of your eye. Not with a frontal assault, but out the corner of your eye. Geez, you seem so unhappy. And because that's almost irrefutable. And the spouse will say, well, I am unhappy because you're constantly hawking me about, or of course I'm unhappy because of, the business, so that they'll give you a reason.
A, B, C, D, E, F, G.
And then you can just say, well, yeah, I know all that. But what I meant was just I'm not saying that you're psychotic. You're not unhappy about crazy little Martians. All I mean to say is that you're unhappy. It seems to be eating your guts out. And I feel for you, and it's you're unhappy, so you ought to get a consult about that. You say, well, what is a consult going to do about it? And so, so the corollary to not getting into a fight that goes 3 times louder and louder, and basically just some point slithering away and saying, oh yeah, I agree with, I'll think about it, and pointing out that you're just unhappy, is just to say, oh yeah, you're probably right about it. When you say disarmingly that, oh yeah, you're probably right, right?
It gets them thinking.
Then all you need to do is get the process kind of thinking. You shouldn't relent, just say, but also I don't think you need to be consistent. So if on occasion you want to beat your spouse over the head, and then on another occasion you want to come back and say, geez, hon, you've just been so unhappy, I feel for you. So if you want to kind of kamikaze and be inconsistent, I guess that's 3 things. I believe in inconsistency.
Oh, really? That helps?
Yeah, I believe in inconsistency.
Oh, okay.
You can catch. Remember, you're dealing with the unconscious here. Internally, there is a part of your partner that wants to get well.
Right.
And you're trying to make alliance with that part.
And you're trying to figure out what will work for them.
You're shouting, you're sending in like messages in a bottle. But that part is also being bludgeoned by the same part that you're being bludgeoned, meaning the depressive part. So you're trying to speak kindly or shout a message from a distance to the part inside that wants to get help. And you should never get nihilistic and think that your messages aren't being heard. Right. But you should go by the rule of 14, which is that on the 14th try, it will be heard.
Is that true?
Yeah. But,
okay.
It may be somebody else's 14th try. So
don't give up. Don't give up.
Do not give up. And because there is another part of the self that's operating internally that strives for health. Right. Even though it looks like the part that strives for not health is very, very much in prominence. Anyhow. Right. That's it for now.
Okay, wait, I have the last question.
Oh, the last question. Okay.
Last question is, when someone comes to you and they're depleted and they're like, okay, I have no hope, what is the message of hope that you give them?
What's the message of hope you give them?
Me?
Yeah.
That there's always tomorrow.
That's a very good one. I like that. I don't know if I can do better than that.
So I'll phrase it better. What does hope mean to you, doctor?
I see hope through a prism of, the layers of the unconscious, the subconscious and consciousness. If somebody says to me, there is no hope, it's almost like saying there's no God. So the correct answer to that is, that's what you think.
But some people really think there is no God and they have hope.
That's right. So, but if somebody comes in and says there is no hope, well, it depends what they feel like there's no hope. Sometimes no hope is on the road to making peace about something. Right. I don't think there's any hope in my getting that girl. And the correct answer might be good riddance.
Right, right.
One lady was asked out by a guy who was totally, infinitely rich gigolo type guy.
Mm-hmm.
Probably seen his name in the page. And she was so flattered. Oh, well, I'm going out with this guy, but he's going out with a million different women. I said, yeah, so? She said, I'm not sure there's any hope. I said, well, okay. So she said, but I want to go out with him anyhow. I said, okay, well, can you go out with somebody with there's no hope? So she said, I'm not quite so sure. So I said, well, there's one way you might be able to manage it. What's that? You set a limit on the relationship. Set a limit? What do you mean? I said, well, you set the limit at 1 year. 1 year, no matter what, come hell or high water, it's over. Over. And you let him know. It's like Cinderella at the ball. When the clock strikes 12, you're out of there.
Right.
So she was doing this, and so they were getting close to the 9th month. I said, have you thrown your farewell party?
Right.
She said, well, what are you talking about? I said, well, it's over in a year, right?
Right.
She says, well, I wasn't so sure. I said, you said that this was only going to be a year. I think you better stick to your plan.
Right.
Of course, as she started to plan a farewell party, this guy who was the major gigolo began to get all kinds of, what are you talking about? Nobody's ever left me before. I leave them.
Right.
So suddenly giving up on all hope became the precondition
of hope. Of connection.
Of connection to that. But I told her, it was like Tolstoy's thing. I said, the only way that you'll possibly keep him interested is if he sees your back walking out the door. Mm-hmm. So she had to really integrate that particular lesson, that she could keep him interested as long as she would sort of hold this barrier. Because it was the nature, she had to give up hope in having him to sort of have some of his interest. So that helped to work through that, the idea that the no hope was a signal.
Interesting.
So sometimes no hope is a sign. So I think it really depends. I'm using a slightly kind of, playful example, but it depends what, hope is about.
With mental health.
Sometimes hope's about, am I going to get over my cancer? And somebody had consulted whose wife had, cancer, and they were very religious. And I didn't know there was such people, but they consulted a seer. A seer in, is that right? Yeah, a seer in Jerusalem. There are people who will function as seers.
Yeah.
So the seer said, I don't think she's going to make it. And they said to me, what do you think? I said, well, I'm not sure, but it sounds like, the issue is in my world isn't always, are you going to make it, but how are you feeling about this, and what are you doing with the time that you have?
Right.
Not with the time that you don't have. And the seer isn't so much important as the desire that you two have expressed to sort of be together forever.
Right. Right.
So, which to me is, really, pretty beautiful. And you don't even know that about each other, and because you're so caught up in the things of making life happen and cooking and making weddings and all. And, maybe the first time we've actually sat down and really declared, but we, just in plain and simple terms, but we want to be together forever. It was a funny kind of, I don't know if I'm answering your question. What do you do if somebody says no hope? I guess you make out of it what you can,
Do you try to give them hope?
Well, nowadays when people come in depressed, they have no hope. They routinely have no hope.
Right.
So
I hear that often. I don't think I'm different. I'm not going to change. This is going to be forever. Is that bleak?
I was in the Philippines. I was in the Peace Corps. There was a farmer that I had helped with he had a depression, and there was a psychiatrist in the Philippines who was there. He'd been at downstate, and long story short, he had gotten me some antipsychotic medication, which I'd gotten to this farmer. After that, there were a whole bunch of people who showed up at my door looking to get some of that medication because they knew I treated this guy. Mm-hmm. And I had thought that it was a placebo. Because they knew that they didn't know what the medication was. Mm-hmm. But later on, these were native people. These were people who had kind of pantheistic gods and very primitive. And later on, somebody said, no, it wasn't placebo. They don't know what the thing is. But one of the medicine men had extended his whatever over me and had let out the word that I was a kind of a low-grade god who was doing battle with certain kind of, impish kind of negative god that had gotten this guy sick. I said, really? I had been deputized. He said, yeah, and he wants to see you. I said, really? And so I went and I participated in the ceremony in which I was defrocked.
Oh, really?
He took away because he could see that I was getting wasted away with my energy. In fact, I was losing a lot of weight. People were showing up. I ran out of the pills. So I gave them whatever. I had, I had cold medicine, Advil, cold and sinuses. Right. I gave them whatever I had.
Right.
And supposedly people got kind of well. So, I was able to dispense a kind of hope, but it was only I thought it was because I had some special powers because of what I had done. It turned out it was only because I had this aura over me of the shaman. I was actually given shamanic power, and that's why these people came to see me. So I thought a lot about that. People come to see me, and but I wear a white coat, so I represent an institution, and I perpetrate a myth that I can help people.
Right.
Now it turns out I believe a lot.
Right.
In what I do.
Right.
So early in my career, I mentioned to you, I thought I was a charlatan.
Right. Right.
Now I think more of a shaman.
Right.
Because I represent something that now I understand people come in and they imbue you with a certain kind of, even though they have no hope, they still come to see you.
Right. Because they really do have hope.
So I realize that I put on so I don't get this. I don't get complete. I don't get I don't really totally get the guy who stands behind me, who gives people. I never really got the shaman who imbued me with the kind of power to help these people. Up there.
Right.
But they came to my door like nobody's business.
Wow.
And when he turned off the spigot,
done.
They stopped. He said I was getting too wasted from it. It was too exhausting. And he just stopped. He was the first person who imbued me with the power to heal. Wow. And I hadn't met him at the time. Now people come to my door. So I think somewhat it's because of medication, and I have a good reputation. But people are people without hope. They nevertheless have some kind of. It's this larger thing that I don't totally understand.
Bigger than us.
It's bigger than us. It's what medicine moved into and took over from this. I hate to say shamanic sounds so it sounds almost goofy, but it means that the institution. It means our capacity to believe even when we practically have no hope.
Right.
I feel like when I go to a doctor, I don't know what he knows and what he doesn't know.
Right.
I sort of just believe he knows something. Somebody's imbuing him with power,
Right.
He knows how to cut your heart open or your leg open. But it's more than that. You want to believe that he's going to be a healer.
Right. It's interesting because most psychiatrists won't even talk about this other stuff. It's not even in they'll laugh the people away because it's not in their conversation. I'm actually shocked that you're talking about it because most.
Like I say, early on, the first thing I realized when I started to practice was that people had, because of depression, they'd lost totally any capacity for hope. And I was schlepping them on my shoulders and feeling like I was, like these salesmen who was telling them that pink was beautiful.
Yeah.
And now I realize that it's much more than just putting them on my shoulders.
Right.
That, in fact, me putting them on my shoulders is the least of it, but that there's this other larger thing that I just happen to sit in the middle of it, sit in a chair.
Right.
And people are actually bringing into the office with them.
Right.
And I then play out a role. And that's a big part of it. I don't know how big. I mean, the medication is for real.
Right. Right. Yeah.
And, but also, but people want to, it's not a placebo.
No, I understand.
The placebo is the magic that you think is in the pill. But the other thing is what people think is not just in the doctor, but in the institution.
Yeah.
In the institution. So I try to straddle two institutions because I think medicine is good, but more people more people go to yoga. I don't know enough about herbal medicines.
Mm-hmm.
And if I did, that would be I have one colleague who's very, very into herbal medicine. And if you're ever interested, I'll give you his name. He knows a lot about it. And there are more people who rely on that than rely on us.
Absolutely.
Because
it's the new thing now.
It is a new thing because people can read up about it. They can have some control over it.
And there's no such fear of like the chemicals and my brain's going to melt. Am I going to start forgetting? Am I going to start to get fat? Am I going to start to...
Everybody can become their own expert. They don't have to rely on us.
Right. Right.
So
what I think the whole relationship between the doctor, the medicine, and the human that's going through it, I think the human is coming to somebody like you that's an expert, that learned the brain, learned pharmacology, understands the connections and the disconnection, and you give us the tools that say you can do the work and you can heal. You give us permission to heal, and you're standing by our side, and you're going to say, okay, these are the tools that you're going to heal. You're going to have to take these medications. You're going to have to do yoga, meditation, go some trauma healing, and we actually have to do the work in order to heal. But you empower us to say you could do it. And with the relationship, within the relationship of all three, the medicine, the person, I don't think a psychiatrist can heal a person that doesn't want to heal and doesn't want to do the work. You could give them any medicine in the world, they still won't heal. I believe that you empower us and you give us the sense of it's going to be okay. We've done this. We understand the brain. We understand the medicine. We understand what is broken. And this is how we're going to put you together. And by giving us that, it's going to be okay. The hope, I call it the hope, is what gets us to work hard, to get out of our comfort zone, to do the work. That's what I think it is.
I think that's really a rather profound and amazing kind of integration.
I'm going to end off by thanking you and giving you an acknowledgement for walking me through this process, for believing in me, for giving me hope. I don't know what you give others, but me, you gave hope. You gave me clarity. You gave me a sense of comfort. You gave me a sense that I'm not alone. And you gave me a sense of you're okay by not being okay. And the fact that you checked up on me and nothing was dramatic, everything was okay and very soothing, I think that was a big part of my journey of healing. So I want to thank you. Thank you very much for being in my life 9 years ago, that I can speak to you now so many years later. And thank God I'm well and I'm off meds for so many years, and you guided me off of them. And I have 2 more children thanks to the healing process.
Wonderful catching up with you like this. And I appreciate all your thinking on this matter too.
Thank you for joining us and taking the time to listen. I really appreciate it. Please hit the subscribe button so you can hear further episodes. If you are listening to us on iTunes, please leave feedback and ratings below. Let us know if there's any topic that you would like to hear from us in the future. Bye till next time.